Welcome everyone to day 2 of our medical and scientific convention. I'm Buddy Pochi from the University of Kansas Medical Center. We're going to begin our abstract presentation series this afternoon. Couple points of housekeeping. If we could, as we go through, please complete the survey on the right of your screen. This is very valuable information for planning future conference material. And at the end of each session, if we want to go ahead and close off our stream and go on to the next presentation, we'd greatly appreciate it. So it is my pleasure to introduce our first presenter of the day. This is Elizabeth Roof. Elizabeth is a research associate at Vanderbilt University Department of Psychology and is a licensed health service provider with decades of experience in research to improve care for children and adults with Prader-Willi syndrome. She will be presenting on the initial results from the CARE-PWS phase 3 study of intranasal carbetocin. So please join me in welcoming Elizabeth from Vanderbilt University. Thank you very much.
Thank you so much, Dr. Poach. So I'm going to share my screen now. So I'm really excited to be sharing the results of the CARE-PWS study. And apparently I'm all the way at the end. Hold on one second. So just a little disclosure information. I'm the clinical advisor for Levo Therapeutics. I'm also a sub-investigator on the CARE-PWS study. The CARE-PWS study is sponsored by Levo, and I'm also a sub-investigator on a couple of current studies and several previous clinical trials. Also have gotten previous research funding from PWSA, FPWR, and NICHD.
Elizabeth, I'm so sorry to interrupt. We're getting some feedback that the slides aren't posted. My apologies.
Okay, no, all good. Hold on one second. Let me try that again.
We should be able to do it from the Zoom program and hit the button that says share screen.
Yeah.
There we go. Thank you.
Okay. So sorry. And I know there's a side thing on there, and I apologize in advance for that. I'm having a hard time with my computer this morning. I think a lot of people are. So talking a little bit about, I'm going to go back one slide. Okay. Talking a little bit about oxytocin, there's been a real interest in oxytocin, right? Because we know that it's thought to be deficient in people with PWS. It's a natural hormone that plays a role in many of the areas affected by PWS, like satiety, anxiety, and social and emotional behaviors. As much as people want it to be a love hormone or a trust hormone, it's a lot more complex than that. So multiple studies looking at brain autopsies in people with PWS have found a reduction in oxytocin producing neurons, and oxytocin replacement has actually been shown to rescue a PWS mouse model in those mice. And so again, replacement of oxytocin has had mixed results, right? Some worsening behavior at higher doses may be related to those negative off-target vasopressin effects. You think of the Einfeld study done and how people with almost higher doses had some aggression and outbursts. I think it's important to know that we don't know exactly everything about it, but we do know that at higher doses, it seems to have some untoward effects. Enter carbetocin. Carbetocin is an analog of the endogenous neuropeptide hormone oxytocin. And so again, it's important to know that it's very selective, and carbetocin also has a prolonged half-life. It's got that selectivity, so it's not hitting those vasopressin receptors. And so that's really important for us because it allows us to dose at a higher level and not stimulate those vasopressin receptors. There's a long history of IV use in labor and delivery in over 10 million women, which gives us a lot of safety data over time. So we, along with the University of Florida and Winthrop, ran a successful phase 2 study using the intranasal version of the drug in patients with PWS in 2014. Given the long hours we spent with families, basically 24 patients over a period of 6 months, we got to really see the firsthand effects of what intranasal carbetocin did. And again, I'm going to be talking a little bit about how that study led to the phase 3 study. So again, it's important to note that the phase 3 study was placebo-controlled, it's double-blind, multi-center, and it was used to evaluate the efficacy, safety, and tolerability of 2 different doses of carbetocin, the 9.6 milligram dose and the 3.2 milligram dose. These were administered 3 times a day because what we wanted to say is that it mimicked the phase 2 trial, and at the same time, it also is how oxytocin is released around mealtime. So again, it basically mimics that. Originally, it was planned to enroll a sample size of 175 people with PWS. They would be genetically confirmed, ages 7 through 18, and those are about school-age kids. So after a 8-week placebo control period, all participants would receive active carbetocin over a 56-week long-term follow-up period, and then would be given the chance to do an ongoing extension period. And many of those patients continue on at this point. There were a total of 24 sites, 19 in the US, 4 in Canada, and 1 in Australia. So again, that is kind of how the study started. And this is just a study schematic. It basically shows that if patients were randomized to the 3.2 milligram dose, they stayed on that dose for the long-term follow-up period. If patients were randomized to the 9.6 milligram dose, they stayed on that dose for the long-term follow-up period. Placebo patients were pre-randomized to transition to one of the 2 doses after the first 8 weeks. And so at that point, everyone after the first 8 weeks is continuing on medicine through that long-term follow-up period. And then, wouldn't you know, COVID hit. So because all of the study measures were subjective or observer-reported outcome measures, this was going to be very difficult. There were radical changes that happened in the midst of COVID. And I think, like a lot of people, we all thought that would be a few weeks, maybe a few months. And here we are 15 months later, and we're still dealing with some of the issues with COVID. Given the fact that so many people who didn't have Prader-Willi experienced increased anxiety, caregivers who are now responsible for dealing with homeschooling and meal preparation and every aspect of their person with PWS's kind of day-to-day life, there's obviously some real anxiety and other changes that happen. It's a lot of together time. And so that changes routines. It can change how meals are prepared and when they're prepared and how things go food-wise. And I told somebody recently, you're so close to the kitchen, how do you not be thinking about food all of the time? So again, there were some real things that COVID did that I think it's important to really know about. I think it's really important to see that, basically the FDA agreed to Levo's proposal to conduct pre-specified primary efficacy analysis based on the efficacy data through March 1st, 2020. And so at that point, there's a primary analysis set that includes all patients who enrolled at baseline and at least 1 post-baseline visit prior to March 1st. And so basically that is where we're going to be talking about those data that we got from 119 patients with Prader-Willi syndrome. So here you can actually see basically the kind of, how people were distributed very evenly through the different dose regimens. There's not a lot of difference there. If you look at the people in the primary analysis set, it's right around 40 people for each one of the groups of placebo, 3.2 milligram dose, and the 9.6 milligram dose. So here are the baseline demographics that we see. And so you can see that the arms were well balanced across a range of measures, including age, gender, BMI. There are no weight restrictions in this study. And so basically people didn't have to have a certain BMI to actually participate. And so I think it's important to know that the BMI range was right around 26 for all groups. And anyone who knows PWS understands that weight and BMI aren't a good marker for hyperphagia. You can be quite thin or of normal weight and still have incredible amounts of hyperphagia. So it's important not to penalize people for parents who do a great job of controlling those things with environmental things. So here we actually see the efficacy measures here. So randomization across the 3 arms was equal. The 9.6 milligram dose was used previously in the phase 2 trial. So that dose was selected for the primary endpoint analysis. The 3.2 milligram dose was evaluated for the second endpoint. And both HQCT and SIBOX were evaluated for each of these doses. I think we know that the phase 2 trial used the HQCT and the SIBOX, and so those were obviously a given. One of the interesting things is that the PADQ, which was developed specifically for people with PWS, was used in this trial, looking really at measures of anxiety, behavioral kinds of feelings of anxiety. So things we can like measure and see and parents can observe. And so we know that people with PWS are very likely to be anxious. And so it was really good to have an endpoint that captured the kind of PWS specific anxiety, which we think about as being different than people who have other genetic disorders or even typical folks who might have anxiety. So again, we see some real differences as far as adding some things and also looking at the clinical global impression of severity and change here. So parents and clinicians would rate how much the kid kind of started out with as far as how much hyperphagia, how they kind of fit into the global kind of fit of PWS. If you're a clinician who sees several hundred people with PWS, you could actually determine severity, whereas a parent has one kid, usually with PWS. And so basically they're kind of looking at their kid based on their experience. Clinicians have sometimes a broader experience of other people with PWS. And so we got that to kind of anchor the other endpoints to really see where change was occurring. So here you can actually see that when the data was actually given, we actually have placebo had a 2.2 change on the hyperphagia questionnaire. The orange is the carbetocin 3.2 milligram dose. The blue is the 9.6 milligram dose, and the yellow is a pooled population of both 3.2 milligram and 9.6 milligram. And you can see the changes in the hyperphagia questionnaire from that. So I think what's really interesting here is you can see the consistency and breadth of the carbetocin's effect across multiple measures, extending beyond just hyperphagia. So here what we have is that you can see that the hyperphagia was improved, anxiety was improved as measured by the PADQ, and clinicians and parents both rated change of symptoms from baseline to week 8. And so this is that 8-week double-blind period. So compared to placebo, you can see that the 3.2 milligram dose is different. And because the dark orange boxes show what is significant, statistically significant across those multiple kinds of measures. And so the 9.6 milligram dose improvements didn't reach statistical significance. So the study technically missed the primary endpoint, but I think it's important to note that that independent cohort of the 3.2 milligram dose did show some significant change across multiple measures. And people who understand PWS know that it's not all hyperphagia, right? There's so many complexities and problems that folks are dealing with. So I think it's important to know that this drug actually affected anxiety as well in a positive way, and just general kind of global impression of severity and improvements. Here you can see again the hyperphagia changes, and this is actually through baseline from weeks to week 16. So this is a longer period of time. At this point, there is no placebo arm. Everyone is on active drug. If you look at this one, you can actually see that the placebo, the light orange, the placebo, people who actually changed to the 3.2 milligram dose. The dark orange are people that started on 3.2 milligrams and remained on 3.2 milligrams. And then the light blue are people that started on placebo and then ended up on the 9.6 milligrams. And those on the dark blue are those who started out on 9.6 and remained on the 9.6 milligram dose. So again, I think it's important to look at those things and to see that this was really impressive because again, we see changes of a study that was cut short by COVID. And here you can again see that the 3.2 milligram dose reduced hyperphagia more than the 9.6 milligram dose. It's important to notice these effects appear to be durable over time. They still continue to actually show change over 60, 64 weeks of treatment. They continue to go down. And again, what we see is that the red triangle is basically the 130 people, and it shows where their hyperphagia score is as far as at the beginning of the study. So somewhere between a 22, 23, kind of like that. And given the fact that we developed the hyperphagia questionnaire and the max score is 36, you can see they have some significant hyperphagia symptoms. And these things actually went down over time and continue to go down over time. So again, the results show that here, that over the full 64-week period, there's continued improvements for those patients who stayed in the study. After the data read out, all patients were actually transitioned to the 3.2 milligram dose. And it's interesting to note that the 3.2 milligram dose still seems to outperform the 9.6 milligram dose over time. So here we're going to show the changes in the SIBOX. And so even with the SIBOX, you can see the trends towards improvement over time seem to be maintained. Again, it wasn't significant, but there were definitely improvements. And it's important to note that this measure was used in the phase 2 trial in a very short 2-week period trial. And even though it's not specifically geared towards people with PWS, it's really geared more towards people with kind of garden variety OCD kinds of behaviors. It did show trending towards significance here. Same story for the PAD-Q, with more improvements in magnitude, more like the HQ-CT. It started out somewhere between a 43, somewhere right around there, and continued to go down over time and sustained over time. So I think here's the efficacy of the actual study. So 2 placebo-controlled studies demonstrate that intranasal carbetocin effectively reduces symptoms of PWS. While the 3.2 milligram dose wasn't previously chosen as the primary endpoint, it nonetheless achieved significant reductions in hyperphagia. There is internally consistent effect observed with the 3.2 milligram dose across multiple measures, in addition to the HQ-CT, including the PAD-Q, the Clinical Global Impression of Change, and the Clinical Global Impression of Severity. A strong signal is seen when pooling the active doses for both the HQ-CT and the CGI, Clinical Global Impression of Change. The improvements in PWS symptoms are sustained over the 64-week period across both doses. So that is very encouraging. Here we're going to talk a little bit about the safety perspective. So it's very similar to the phase 2 experience as well. So there were no notable differences versus placebo, with the possible exception of some nosebleeds and flushing. So again, the flushing resolved incredibly quickly within 15 minutes. It's kind of a warm feeling, tingly feeling. And we saw that people had kind of flushed cheeks, and they actually said that they felt warm. It resolved incredibly quickly, but overall, carbetocin was well tolerated.
Hi, Elizabeth. We're coming to the close of the session. Can we wrap up pretty quickly?
Yeah, absolutely. I've just got a couple more slides. So again, long-term follow-up period, you can see that the safety results still held. We had some additional safety data. So again, sponsor DMC reviews showed no concerns with safety signals. D-dimers were performed with an abundance of caution and showed no apparent trend for change from either treatment or baseline. And it's important to note that DVT or pulmonary embolisms haven't been encountered to date with this population. Serum sodium was also monitored just to make sure that there were no untoward vasopressin effects. And again, showed that there were no problems with that. So overall conclusions, intranasal carbetocin reduces hyperphagia and anxiety behaviors in people with PWS with maintenance of improvements over time. The data support a highly favorable overall safety and tolerability profile in participants with PWS. The sponsor and the independent data monitoring committee have agreed that the aggregate data support continued advancement of the 3.2 milligram dose as the lowest effective dose. And the sponsor is working closely with the regulatory authorities to bring LV-101 to patients as quickly as possible. Thank you very much.
Thank you so much. That's a wonderful presentation, such important work. I don't know, we're going to run out of time fairly quickly here. We did have a question about whether a 3-point change in the hyperphagia questionnaire was considered significant specific to the primary and secondary analysis. So you feel these are meaningful results that we're finding?
I definitely think it's meaningful results. And again, for a lot of our families, the idea that hyperphagia could be dialed down to a level where they can manage other kinds of issues like schooling and education and therapies is really important. So again, I think it's important to see that that was the change that we saw, and it continued over time. So again, change over time of almost 10 points. I think that's really compelling.
Wonderful. Well, thank you so much. I think we're going to have to end with that and move on to the next talk. A wonderful meeting with you, and thank you so much for coming to our
Thank you so much.